So I'd like to welcome everybody to the second meeting of the day, the International Tracheostomy Symposium. And I'd also like to thank again, for probably the third time now, the organising committee who have done an absolutely amazing job in putting this together. I think it follows on perfectly from this morning's meeting, the Global Tracheostomy Collaborative, which was a really inspiring meeting with some fantastic talks. And there is a real true international flavour about today. We've got numerous international speakers, very, very high-powered international speakers, but in the audience we've got true representation from around the globe. So we're going to kick off this afternoon. We've got a great talk, what I'm sure is going to be a great talk. So I'd like to introduce to the stage Sam Radford. He's a physician and intensivist and has a true interest in tracheostomies amongst his many and varied interests in education and research. And also Associate Professor Sue Burney, one of the lead physiotherapists at the Austin Hospital, who again has a great interest in this area alongside a very, very impressive research career. So if I could introduce them to the stage to talk about the start of the journey, who gets a tracheostomy and whether you are not the intensivists extubate or tracheostomised. Thank you.
Thank you, James, and also a big thank you to the organising committee. It's a pleasure to be invited to come and demonstrate with Sue and myself a team-based approach to this very diverse team-based audience. We'd also very much like to thank our own teams that let us practice our own local expertise, because it's not just our ICU patients, staff and teams there, but it's also the interface with the broader hospital, particularly TRAMS, as well as the other managing units. Now, if I may. So, really, this is a difficult question. Thanks very much, organising committee. And there are lots of different ways that one could approach it. You could approach it with an evidence base, you could approach it with a pragmatic, here's what we do. Or you could approach it like they sort of did in that great Australian piece of cinema, The Castle, which is to sum it all up by saying it's the vibe. We'd like to try and make it a little bit more tangible than just it's the vibe. We'll see where we go in terms of how we make our decisions on who gets a tracheostomy, to extubate or tracheostomise. So tracheostomies really do represent, or the decision to tracheostomise or to extubate really represents a crossroad in the patient journey when they've had a long critical care illness. And you could go down extubate pathway, you could go down the tracheostomise pathway. It's also worth acknowledging that it's not just a binary decision. There's often a third really valid choice, which is deciding not to decide and putting it off by another day, which often becomes another day. So all of these turns are active turns that one can take. To try and shed a little bit of light onto the person or persons that we're describing or that fit this conundrum in front of us, we thought we'd put up some case illustrations. Have a think about this lady. We'll come back to her at the end. But we've got a 78-year-old lady who's been admitted 9 days ago following emergency surgery from a ruptured diverticulum. She had a stroke 2 years ago. She got a 30-pack year smoking history and she stopped that 15 years ago. She's hypertensive. She lives at home by herself independently. However, over the last 6 months, she's had increasing fatigue, has lost weight, is managing at home but not going out. Her daughter's reported she's more forgetful, and 2 weeks ago she had a severe coughing attack whilst having a cup of tea. She's just started to wake up this morning and she's intermittently following some commands. Currently she's febrile at 38.5, her mean arterial pressure is 72 millimetres of mercury, noradrenaline requirements are still substantial at 15 micrograms a minute, her heart rate's 110 in AF, and her respiratory rate is steady at 15 breaths a minute. Her chest x-ray, as one could imagine, after 9 days in ICU, shows mild bibasal changes. She's on pressure support ventilator mode with 12 and 5 centimetres of water of pressure support and PEEP respectively. And she's on 40% oxygen with SATs of 94%. Your ABGs, you can see there, I'm not going to read out every last detail on there, and she's producing enough sputum to need once hourly suction. So this is the sort of person that we're describing. This is the sort of person that regularly comes up as the decision to be made. Do we extubate this person or do we move on and tracheostomise? So we'll try and outline in our talk some of the ways that we go on and make these decisions. That we make these decisions based on on factual information that we gain from patient assessment. We make this information based on the environment and the team around us. We make it based on what day of the week it is. And we also, at times, try and turn to the literature for some guidance as to say, how can we better make these choices? I'm going to turn to Sue and also, by the end of the talk, and get her to outline a prospective way that one can help make decision support tools. So we thought we'd give a little bit of demographic background, and a big acknowledgement, thank you to Graham Duke for his data here across the last 10 years worth of data here in Victoria. As you can see, that there is a large representation of neurosurgical, traumatic brain injury and multi-trauma there for patients receiving tracheostomies, and quite a significant percentage of those patient groups receive tracheostomies. Amongst the smallest in total numbers, but the highest in percentage requiring trachees are the Guillain-Barré population. And thankfully, the group that we see the most of, cardiac surgical patients, that is ventilated patients we see the most of, 32,000, only 2% requiring tracheostomies in the ICU. So this is what the ICU ventilated and tracheostomised population looks like here in Victoria. But it looks different in every hospital. These are 23 major hospitals in Victoria. They're not labelled. I don't know which one's us. Graham knows. And you can see that you could be at Hospital A, ventilated for 1,000 days, and you've got a much greater chance of being tracheostomised than if you're at Hospital X. And so there is a heterogeneity of practice throughout Victorian ICUs. It's not to say that ICU is the sole arbiter of who gets a tracheostomy. We represent 83% of the 840 tracheostomies done, but there's a good percentage done outside of us, particularly elective surgical tracheostomies that are temporary, and then also a smaller number of elective permanent tracheostomies. It's worth noting there in that right column that mortality is a common occurrence. Certainly for ICU tracheostomies, mortality is a common occurrence. And so perhaps then that data that focuses on mortality can make it hard to determine about the quality of your choice. Was it the right decision or the wrong decision? And that we would certainly insist that endpoints look towards functional outcomes, not just mortality outcomes, because we're already playing in a self-selected group. That lady that I described at the outset, she's sick. Her mortality risk is high whichever way we turn. These are the patients in front of us. So, with a childlike sense of wonder, I went for a roadmap. And it's to show that it's a twisty, windy course. We start all the way down here with admission to ICU and we work our way through what might be 2 days, 4 days, 6 days or 14 days. It's all different in different places. And we've got a choice. It's not just a choice at any one point in time though. We can move to primary tracheostomy. We might be successful in navigating our way through successful extubation. We might fail extubation. This arrow snuck in. Hopefully we don't go back to the police or the coroners. And after failed extubation, we move on to secondary tracheostomy as a choice. And hopefully they all lead to discharge from the ICU. Hopefully they all lead to discharge from the ICU intact. So, from an ICU perspective, what are our aims of weaning? When we're trying to separate you from ventilation, we're trying to maximise benefits. We're trying to choose and perform a procedure at the optimum time for those who are likely to benefit. We want to minimise the morbidity and mortality, and we want to avoid an invasive procedure for those who aren't going to benefit. It'd be nice if we could simplify your stay in the ICU. It's nice if you've got less mechanical ventilation. It's nice if you've got less sedating medication. And if you like, that can be a patient-centred goal where you say minimising the ICU length of stay is a really great patient-centred goal and it improves their experience and hopefully their memories of their stay. Or you can take a purely financial point of view and say it minimises the financial burden. It's a payer-centred goal. These are valid goals, but they're very different ways of saying the same thing. So with those aims in mind, who can we prospectively identify as being high risk for weaning failure? So, those that are old, greater than 65 years, and there is most commonly some overlap here with frailty. Certainly delirium is a very common part of ICU practice. Between 40 and 60% of ICU patients, particularly those with prolonged ventilation, can have some form of delirium. Sleep deprivation, limb, muscle and diaphragmatic weakness, all obvious when you look and consider them, not all necessarily obvious when you're looking prospectively at the complex patient in front of you. A big and often underappreciated limitation to successful weaning is that of adequate cardiovascular function. So working left ventricle, not just in its systolic function, but also in its diastolic function, are really important determinants of how successfully you can get off and stay off mechanical ventilation. The neurologic and neuromuscular impediments, again, seem relatively obvious and intuitive, and they certainly fit within the vibe of what it is that is holding patients back. And it can be quite hard to quantify and predict what some of those neuromuscular impediments can be. But certainly when patients have substantial impediments, they run a very high risk of extubation failure. Sue will talk a little bit later about how they developed a scoring system to help predict. So when we as a team are looking to assess patient suitability for weaning, whether that be extubation or tracheostomy, we look at a few big headings. How well is the patient actually interacting with staff? Because engaging that brain is a really important step. We look at some disease-specific factors. I'm going to review very quickly the tracheostomy-specific literature. We look to a structured form of physical assessment. And we also turn to that most important form of medical evidence, which is stuff that done happen to me. It's called experience or anecdote, or bad stuff that happened to a colleague of mine once. These are important ways that colour our judgment. What is also really hard to describe are these ones on the right, the environmental factors. I once saw a very cheeky ICU registrar who was being assessed and examined for his consultant fellowship exam, who was asked, is this patient ready to extubate? And he said, look, I've got a really great structure for assessing this, but I'm going to start by saying it's 4 o'clock and it's Friday, who's on tonight? That registrar was successful. So knowing who's around you, knowing what your team is, knowing what time of the day or week it is, knowing what your departmental culture is like, and knowing also what your hospital's capacity to cope is like are all important determinants in our decisions. So the brain is the most important organ for patient weaning. If you've got a brain that you can talk to and engage with, you've got progress with weaning. And an awake patient can trust you, hopefully, and they can work on their cough, and they can also channel their own determination into successful weaning. It's also important if you've got a trusting, confident patient to maintain that trust and confidence, and explaining to them that failure isn't necessarily a bad thing, it just is, and that accepting that sometimes extubation does result in re-intubation, and maintaining that trust through such a difficult course is important. The departmental factors I've touched on already, that really it works well when you have an engaged team, and I'm thankful to say that we do have an engaged team. Certainly in our hospital with complex spinal patients, extubation is primarily a physiotherapy-led decision and it's medically endorsed. There's nothing more powerful than the raised eyebrow of a senior physiotherapist or liaison nurse who doesn't even have to mouth the words, "Are you sure?" to make one reconsider. This is something you only need to mistake once. So, we talk about patient-centred characteristics, but the other patients also determine the safety or otherwise of extubation and tracheostomy. If I've got 2 liver transplants, a heart coming back, and lots of chaos going on, perhaps it's not the right time to do either tracheostomy or extubate, and perhaps that deciding not to decide and waiting another day is the valid choice. The experience of staff, both on during the day and the night, and their confidence in managing and troubleshooting and detecting problems is key. The surgical support that you get, whether it be from the ENT supports, thoracic surgical supports, cardiothoracic support, or even general surgeons, is absolutely crucial in determining particularly the time of day or day of week. The ICU model of care, we're lucky to function in a relatively closed model of care, but that doesn't mean we don't ask for endorsement and support from the managing teams. Whereas I know that our North American colleagues will often practice in a more open model and constant discussion about the need and the timing and the performance and who will do tracheostomies must also play a part in their decisions. It's also a really important thing to know, if I do this trachea, will it actually make a difference to the patient journey? If the patient's going to stay within the ICU the whole time, then one of those factors, albeit a payer-centred one, how much does it cost, is really negated. So staying in ICU for a long, long time because the ward can't manage isn't as positive an outcome as it may have been for the payer. It may still be a very positive outcome for the patient, but it's a substantial change. This is my suggested approach to a pragmatic assessment of patients, whether you're choosing to extubate or tracheostomise. And I can't really remember too much of the alphabet, so I keep it really simple. A, B, C, D, E. And this can be performed in just 5 minutes at the bedside. Are they awake and alert? What's their airway anatomy like? Is there a cuff leak? What are their reflexes like? B is for breathing. Subjectively, do they look like they could do it all day, or are they going to get knackered? Objectively, what are their supports? What are their volumes that they're achieving? Have they got a high minute volume? Are they going to huff and puff all day and then fade? You can look for careful, structured, rapid shallow breathing indices. You can do a spontaneous breathing trial, and I really enjoy doing, well, not enjoy, I like doing T-piece trials because I particularly like doing these on patients for whom I think they were going to fail, and when you're pleasantly surprised by them passing, I think they've earned the right to primary extubation. Circulation, is it stable or improving? Is 15 of NORAD 35 yesterday, or was it 5 yesterday? Particularly important also to have some sort of assessment of the left ventricular function. The deficits, I would hope that's relatively obvious, the neurologic deficits can be evolving or they can be static. And the expected time course of any improvement would also influence one's decision. I think E is the really big important one. What's the expertise? Who are the employees around? What equipment have you got? Now's an important time to also think about your end-of-life care decisions. This is a crossroads. What are the expectations of the patient, the family, and the managing teams when it comes to weaning? Is this a one-way extubation? Is this an extubation with a bailout to tracheostomy? Is this trachea going in for a finite period? Is this open-ended and remains to be seen? Before you put these in, if you haven't already started these conversations, at least amongst the clinicians, and preferably also amongst patient and family, it's an important time to consider it. As I said, this ABCDE approach can be done pragmatically and quickly at the bedside. So, can the literature help? Apologies to the authors in the audience, but only a little bit. We've looked at some very specific subgroups in some of the literature. Unfortunately, a large amount of it has been retrospective. And so it doesn't really help in that decision-making with the patient in front of me, what do I choose now? And really, when the variables are looked at, what they do is they predict whether a tracheostomy would be performed. They don't tell you whether it was the best decision, they just tell you that it was decided upon. In intensive care, we kind of are the arbiters of what happens. If we decide something's going to happen, it will happen. If we decide that we're going to extubate and palliate, it generally happens. If we decide we're going to tracheostomise, it generally happens. Things happen because we say so. And that's a tough one to measure. And really, the literature itself doesn't give us great forward prediction tools. I'd like to very much acknowledge the support and help of my colleague Andrew Casamento alongside Neil Glazford and Ronaldo Balomo, who are working on a systematic review of this area. And one can imagine that this leads naturally on to developing the statement that really a randomised controlled trial in this area would be great. So, my idiot's guide to the literature. If it's bad, you might need a trachea. If you've got a bad general trauma injury, a cluster of injuries including head, abdomen and chest, that's a positive predictor for getting a tracheostomy. If you've been head injured and you've got a bad brain, I mean, we could spell this out into the fine detail of what the GCS was at day 4, but essentially, if the brain is bad at the time that you're deciding, that's more likely to predict for a tracheostomy. If you've got a C-spine injury, the literature would suggest that a high level, certainly a complete above, any lesion above C4 would suggest for a tracheostomy, and that a complete lesion of C5 and below would also suggest for tracheostomy. That isn't necessarily what's borne out at our centre, but that's what the literature supports. The general ICU patients, I mean, this is a fascinating, massive group, but here the studies really only show 596 patients and 62 tracheostomies. And again, it's kind of obvious. Pneumonia, they've already failed an extubation, and we said they were going to get a trachea. These are the true self-fulfilling prophecies. Lung transplant, again, a very small group. If you get more than one lung transplanted, if you've got pneumonia, if you get re-intubated, and if you had cardiopulmonary bypass, you're more likely to get a tracheostomy. The one area that has had some constructive work done by Sater et al. Is the spontaneous intracerebral hemorrhage group. Again, a very small group within our ICU experience, but an important one. And they've managed to come up with a prospective scoring system called the Trach score. And the Trach score looks at the radiological anatomy. Where was the bleed? Was it a deep thalamic structure? Was there hydrocephalus? And they also look at the GCS at a set point in time. And the combined scores then add up to a predictive tool whereby Those with a high score recommend tracheostomy. Those with a low score can be safely extubated. But again, it's a scoring way of putting together common sense. Those that were bad ended up getting a tracheostomy. It doesn't make it right, it just says what happened. I'd like to turn to Sue to talk about the process for developing a decision tool.
Thanks, Sam. And I'd endorse Sam's comments about thanking the organising committee. It's a great conference or day that you've put together, and it's a real pleasure to be here. One of the issues, as Sam said, with the literature is that it ends up being a self-fulfilling prophecy, because it is, when you look back and you see how many patients got a tracheostomy, as Sam said, they're the ones that we decided. We have a particular group of patients in our unit, which is spinal cord injury patients. And we used to spend a lot of time talking about, should we extubate them, should we tracheostomise them? It's one of the true areas where it really is a dichotomous decision rather than a decision of the tortuous path. And there was really very little evidence to guide that decision and how we might go about it. Because the evidence would suggest, as Sam said, that anyone who has a complete injury above C7 pretty much should have a tracheostomy. The evidence is also largely North American, which is not necessarily reflective of our practice in Australia. So what we were interested to do was to try and work out what factors were important in the decision to either extubate or to perform a tracheostomy in patients with spinal cord injury. Because we did a case-controlled match study early on that showed that if we could extubate patients, they actually spent less time in ICU, and on average we saved $60,000 per admission. So there was not just for the patient's sake, but also a financial imperative. If we could extubate them, it was a better outcome for both the patient and the hospital. So we went through a process that I'm going to describe to you, but this decision-making tree could be used for any process. It could also be equally used about when is the appropriate time to decannulate and not. And I don't think it's for everyone, but it's for those high-risk groups in whom there is debate about what is the right path, what treatment path is the right one. So what we did is we got all of the brains in our spinal unit in ICU and across the unit to come and identify the factors that were important, that actually changed the way, it actually focused the way people made decisions. And we identified several factors. We sent them around Australia to every spinal unit. We asked people to add whatever they wanted. We included whatever they wanted. And then what we did was we developed metrics for how we can measure each of those factors. So, for example, forced vital capacity via spirometry, gas exchange by the PaO2 to FiO2 ratio. And each of those had a metric associated with them. And then we asked prospectively, whilst the patient was there, we asked the clinician who made the decision to rank any or all of the factors that influenced that decision. We then went through to an analysis called classification and regression, and it's a relatively modern technique of regression that enables a decision tree to be made. It classifies patients in a binary way at the end to whatever you want to do, whether it's decannulate or not decannulate. For us, it was extubate or tracheostomise. And it's a graphical representation of how clinicians make decisions. And it's a hierarchical presentation. So the most important factor is at the top of the tree, and the factors that, as factors go down the tree, they become less important, but are all significant in the decision-making process. What the regression analysis does is it finds the cut-off point for each of these variables that's most predictive of the outcome. So for us, for example, at forced vital capacity, at what level of forced vital capacity affected us making the decision tracheostomise or not. And it's displayed as a series of splits, as you can see, and you have at the bottom of the tree, you need to have at least 5 observations at the bottom of the tree. And what we found, which didn't necessarily surprise the clinicians at the bedside, was that forced vital capacity was the single most important factor. And we know now that if they have less than 12 mils per kilo, or around 830 mils for a forced vital capacity, we can be pretty sure the patient's going to need a tracheostomy. If it's greater than that, we then look at their sputum load. So sputum load was the second most important factor, and we classified sputum according to how many suction passes they needed every hour in order to clear their pulmonary secretions. And if they left suction once hourly or less, the majority of patients were able to be extubated. The third factor was gas exchange, but in reality there were so few of those as you can see, only 2 and 3 at the bottom. If PF ratio was greater than 189. It's such a small group, you really can't. It's probably a 50-50 throw up, and that's where all of the other factors become important. So it's a very simple technique, and it's not a difficult statistic to run. And for us, it gave us a template, a prospective template about how we could go about making decisions in a really difficult patient group. And we just wanted to present it today because it really it doesn't take that long, it's not that difficult to do, and clinically it can be very useful. So, back to our case.
So quick sort of show of hands from the audience. Who would be happy with extubating this lady? Who'd be happy going on and performing a primary tracheostomy with this lady? And that puts the rest of you in the deciding not to decide group?
Is there any information that you'd need more than what we've presented?
Excellent. So you're starting at the E end of things, but yeah, what are her expectations? What are the end-of-life care factors and concerns? Yep, fabulous. Any other variables or bits of information? Yeah, absolutely. So reversible respiratory insult or other insults. Graham?
She had a spontaneous breathing trial?
She's not at this stage.
Would you do one?
Definitely.
Yeah, in looking at this lady, this is a lady I would be happy to consider for primary extubation. That's the first choice. Is today the right day to do it? That's another question. I would decide not to decide today, and I would look at her tomorrow morning with a spontaneous breathing trial because it's after lunch now. It'd be uncivilised. But part of the decision to extubate will come down because I'd argue that she has criteria there that make her potentially safe to extubate today. And part of this is also going to come down to that other sort of intangible E, which is employee confidence and engagement and how confident they are in helping to manage a patient. In particular, I would have thought that the circulation aspect of her resolving septic shock, it's reasonable to think that it might be a lot more resolved in 24 hours and that it's always best to take along for the ride a confident senior nursing staff member with you. And when I had this discussion only a week ago, oh look, I'm happy, I'm comfortable, the NORAD's high, but things are heading in the right direction. Oh no, I want to have those skilled hands ready and able to help me, not saying I told you so, and then able to help me. So you can take a structured look at this lady. You can look at her A's, B's, C's, D's and E's. But yes, there are some missing bits of information. Are there other things in there that worry you? That for those that were considering tracheostomy, what are some of the main determinants that make you concerned that trachea might be the best choice here?
I would like to ask the doctor, what is her opinion for the patient?
Yeah, opinion, absolutely crucial. I'm hearing weakness and speech issues. Does anyone get worried about the coughing attack and the cups of tea?
Not really.
Yeah, again, I think there's a whole spectrum there of not really to yes and furious agreement. And I'd suggest that even within our unit you'd see a spectrum of opinions as well. So these really aren't clear binary choices with only a good or only a bad outcome. Should we move on to the next case?
How are we going for time? Yep.
All right. In that case, we'll skip the next case and we'll conclude that really to say that successful separation from ventilation really is a team endeavour, that the tracheostomy literature doesn't yet shed a great deal of light on prospective decision making, so there's a big wide opening there for those interested. And it is possible to develop prediction models. It'd be great to have some randomised controlled trials. Certainly functional outcomes are just as important, if not more important, than mortality-based outcomes. And we think that such tools should be used in daily practice alongside the pragmatic patient assessment and planning. Thank you very much.
Can I ask how she did?
She's not real.
She's fictional.
Makes it difficult.
She lived happily ever after, as all good fairy tales are.
Thanks to Sam and Sue. That was fantastic. I'd like to introduce Linda Rotella up to the stage. The next talk is by both Linda and myself, and the program's got Linda talking first, but actually I might launch things off. let me just get the right slides. Okay. So we've tried to be clever and called our talk Masking the Problem, but really what we're going to be talking about is this tracheostomised and ventilated patient and how we, as part of a statewide service, which I'll elaborate on just shortly, try and get them off ventilation using, or off invasive ventilation with the eventual aim to decannulation using non-invasive ventilation. Both Linda and myself work within the Victorian Respiratory Support Service, and for those international guests, Victoria is the state of which Melbourne is the capital city, and so it's got a population of about 4 or 5 million. And we do two main things with this service. One is that we help look after people that are ventilated at home, either via a tracheostomy or via mask ventilation. But the other thing is we provide a centralised weaning service. So patients that are difficult to wean in intensive care units from around the state, we'll take their patients and try and wean them with these will all be, or nearly all be, tracheostomy ventilated. So we will be attempting to wean them off ventilation and obviously to eventually try and decannulate where possible, and if not, to look at trying to get them home. So the talk is quite a quick talk. I've got plenty of great stuff this afternoon, so I'm just going to run through the first 3 points, really for those that aren't quite as familiar, and I suspect there's not too many in here that aren't, but just what is non-invasive ventilation and why we try to get people off invasive ventilation as soon as we can. And I'll talk a little bit about the literature, which a little bit of what Sam said. There's not a huge amount that guides us in what we do. And then I'll pass on to Linda for the more clinical and practical aspects. So this is the non-invasive ventilation that we deal with. Obviously, smaller machines that are more readily usable and more easily used at home. And non-invasive ventilation is the provision of ventilation without the use of an artificial invasive airway like an endotracheal tube or a tracheostomy tube. So in this day and age, it's normally mask. I'm showing here smaller machines, but even a big, complicated intensive care machine, if you're ventilating using a mask, that's called non-invasive ventilation. An important point here is CPAP therapy. CPAP therapy looks like this, but is not ventilation. It's not non-invasive ventilation. That's an important thing to take away from this. Uses the same masks, the machines look the same, but it doesn't help with ventilation by and large. So, non-invasive ventilation is a weaning tool. The overall literature suggests this, and I'll go into that in a little bit more detail, that it is associated with a decrease in mortality, with a decrease in ventilator-assisted pneumonia, and also a decreased length of stay in intensive care and also hospital, but also a decrease in the total duration of mechanical ventilation. But relatively speaking, it's a newer thing. Really, in the literature, it was only first described in 1992, where a group at the Brompton Hospital described their experience with using non-invasive ventilation to wean 22 patients. So a small study, not controlled, but important nevertheless. So they had success in 18 patients of getting them onto non-invasive ventilation. And the good thing about this study was that it was an open cohort of patients. It wasn't just the COPD patients, it was also neuromuscular disease and chest wall deformity patients, which we deal a lot with. And 7 of them had tracheostomies. So many centres around the world were doing this at the time and continue to do so, but it took until about 1998 for us to have a controlled study. And this study was just in COPD patients, and it was a randomised controlled trial looking at what we're interested in here. It was a multi-centre, so 3 centres and 50 patients overall. And it did show positive findings in those outcomes that we were looking at in reducing mortality, so a 60-day mortality, in reducing hospital stay, in reducing ICU stay, and in reducing ventilator-assisted pneumonia. And from there, we've had numerous studies that have been looking into this in different patient populations, but the majority of them have been in the COPD population. In more recent years, we've been having studies with greater numbers. So since about 2012, there's been 2 studies with patient numbers of above 150. And so we're getting a body of research that lends itself well to a systemic review and meta-analysis. And the Cochrane Group did that last year and have published that early this year. And they looked at 16 studies which they'd classified as moderate to good studies, so all randomised control studies. And again, this showed that the initial studies that showed the decreased mortality, decreased ventilator-assisted pneumonia, decreased incidence of weaning failure, decreased length of stay, duration of mechanical ventilation, and other adverse effects. It was a true effect across this meta-analysis. The interesting thing in the last 3 of my slides before I hand over to Linda, from our point of view, is that we're probably getting towards the numbers where we can start to see whether or not this effect is just within COPD, where I think it's without doubt, or whether or not the mixed group. So the neuromuscular diseases, the chest wall deformities, the people with COPD and something else, whether or not the effect is true in them. And I don't know that we can take anything conclusively from this. If we look at the forest plots, and there's 3 slides, so the first one's on mortality, you can see there's a clear effect with COPD. Is that coming up there? Yep, good. And look, a suggestion of a benefit with the mixed group. And it's very similar with the effect on weaning failures. Clear effect here in COPD. You know, suggestion of effect, though it does cross the line. So, and then the other one with the ventilator-assisted pneumonia, I think is a little clearer that it does look like there's a definite effect. So there is some literature behind what we do, not enough, and obviously we've got a keen interest in working on that literature, and in particular subgroup population. So as with most meta-analyses, they're performed, and then we have the statement that more are needed, and certainly from our point of view that's true. We need bigger randomised controlled trials. We need other centres to come on board with us because of patient numbers, and we need to be looking at subgroups, in particular those with tracheostomies, and teasing them out from the population that we're looking at. So I'll hand over to Linda, who will talk about more of the practical aspects of what we do at the Austin Hospital.
Thanks, James. I think that's a reasonably quick skate over the literature, but I guess the take-home message for me from all that was that using non-invasive ventilation as a weaning strategy for extubation has got some reasonable evidence behind it. Certainly it has an effect on mortality and on some of the morbidities associated with being invasively ventilated. But it seems that most of the literature really concentrates on that group who've got endotracheal tubes. There's very little in the literature around using non-invasive ventilation as a tool for decannulating a tracheostomy. And that's exactly the group that I'm wanting to concentrate on here today, because they're the sort of people that we get in our unit all the time. All our patients that come to the weaning unit are tracheostomised by this stage that James has already spoken about. And they all fall into this difficult to wean or the prolonged mechanically ventilated group. And that group has been defined by a couple of consensus conferences in the past as those who are needing more than 6 hours of ventilation over 21 consecutive days, or who've failed spontaneous breathing trials 3 times, or who've taken more than a week since their first spontaneous breathing trial to actually wean. If you don't quite reach those criteria, you're still in the difficult to wean category, and in reality, most of those difficult to wean people end up being prolonged mechanically ventilated group anyway. There are a smaller group of patients who are just at high risk of failed decannulation, who may have had a tracheostomy fairly early in the course of their stay in intensive care, and most of those would be at high risk of failed decannulation because of an underlying comorbid condition. Of course, it's not often an or situation. Frequently, it's an and situation, and they're the sort of patients that we're talking about in our weaning unit. The diseases that they may have that cause them to become part of this prolonged mechanically ventilated group, frequently it's divided really into 2 main subgroups. You've got people with restrictive lung disease and those who've got COPD, and there's some good literature around the COPD, as James has already spoken to. So those with restrictive lung disease, varying sorts of diseases obviously, but those may have stable restrictive lung disease such as kyphoscoliosis, or slowly progressive diseases such as the muscular dystrophies, or even a few of the more rapidly progressive diseases like motor neurone. We also get quite a reasonable cohort of those with recovering neurological conditions, such as ICU-acquired weakness or GBS. And Sam pointed out in his slides there's quite a lot of those that end up with tracheostomy and then in a weaning unit. So how do we decide, once these patients are in our weaning unit, whether they're ready to start using non-invasive ventilation as a tool to progressing their care through the hospital, getting the tracheostomy out and hopefully moving them on to the next stage, which would be rehab and ideally home. So you can really break down the things that we look at into these sort of 6 categories. Like when you're deciding whether a patient's ready for a spontaneous breathing trial, there are many predictors you could use, equations you could apply, etc., etc. We don't tend to drill it down into such fine detail in a weaning unit situation. We very much rely on our multidisciplinary team and on the skills associated with the various members of that team, all feeding into this decision making. So these 6 areas, everyone will contribute to their bit of expertise and knowledge to these things. Clearly, we want a patient who's only got a single organ failure, and it goes without saying that organ failure needs to be respiratory. It's really a bit of a no-brainer to try and start weaning someone who's got a concurrent cardiovascular instability or some other major organ failure. Again, those are the patients that would rarely be in our weaning unit anyway. One of our criteria for accepting them would be that they have stable single organ failure with minimal or at least stable oxygen requirements. Again, you don't want someone who's got some active chest problem going on or pneumonia or infection. You want someone that's got stable and minimal oxygen requirements. Ideally, we want them to have been established on some reasonably satisfactory spontaneous breathing time. In our unit, we like them to be weaning or being able to be off mechanical ventilation for at least sort of 6 to 8 hours a day, ideally 12. Some of the very early literature that James alluded to, done about 20 years ago, actually looked at tracheostomised patients, and their criteria was to start NIV, you only had to be able to stay off ventilation for 10 or 15 minutes. That gives a very small window of opportunity for a lot of patients and adds incredibly to the anxiety around the whole situation. We would not probably consider that is long enough in our unit. Again, we're not in an intensive care situation, so we have a different staffing mix, and we would want the patient to be a bit more established with spontaneous breathing capacity than that. So ideally, at least 8 hours off, ideally a bit more than that. What I like to call an office day. I like to see them off from 9 to 5, having a bit of a rest and engaging in life, being off a ventilator. We'd always take an end of day or an end of that 8-hour session gas to make sure that they're not developing respiratory failure over the day that isn't sort of obvious. We want them to be actually quite crisp. Obviously, they need to be able to tolerate the passive mural valve. That's a bit of a no-brainer. We've got to be able to get the cuff down and the valve on for considerable periods of time. And this is where our speech pathology colleagues have a lot of input into our weaning patients and the progress through the unit. So they need to be able to protect their airway. They need to have a good patent upper airway and be able to use their voice, etc. Clearly, we need to have a good plan for secretion management. Of course, we wouldn't be considering reducing ventilation in a patient who had an active infection and a huge sputum load, and we need to have some good strategies in place to help them deal with secretions. And last but not least, they need to be cognitively intact and pretty cooperative. And as Sam pointed out in one of his slides, the brain is one of the most important organs, and I would underline that about 4 times. You need someone who's going to go with you on this journey because it is a significant step forward for them. It often can be quite anxiety-provoking. So how do we start out? We've got an very experienced and stable staff and an environment that's conducive to doing these sort of trials with patients. So we set it up right from the very beginning. We try and reduce the stress and anxiety around it for everybody, staff especially, but definitely for the patients and for their family. So a fair bit of time is spent with the family and the patient explaining what we're going to do, why this stepping forward to a different sort of ventilatory support is really important and how it may well help us remove that tracheostomy, which is often the defining moment for getting that patient out of hospital or onto the next stage. So getting everybody on board and having a very experienced staff around you to deal with it is really important. Selecting machines and masks or your equipment. Obviously, we're pretty well set up for this sort of business in our weaning unit, so we have the right equipment. But it's really important to have machines that will work with the patient well. So we use the dedicated home care machines. They're all bi-level pressure ventilators. We rarely use volume ventilation in this way. It can be done, and in the earlier studies it was done that way. It tends to be all pressure now. I'm not going to go into too much about that. So we use those dedicated machines that are much more able to synchronise with patients who are awake and spontaneously breathing as well, and have a capacity to spontaneously breathe. And we use full face masks by preference. We do have nose masks, etc., but my preference is always to get them on full face masks, which is better able to deal with leak and generally works better for patients. So there's a fair bit of talk around the equipment and getting things set up right and having the right stuff that looks simple, easy to use and will work with your patient. Obviously you've got to have a fair bit of time set aside too. So there's quite a bit of time spent during the day playing around with the equipment and getting people used to things. So they need that practice during the day. Obviously they've got to have their valve on. Once they've got the valve on and a mask on, then any oxygen and humidification requirements they need are all done via the non-invasive ventilation. There's no need then to still continue with trachea shields and heater bases and hot air blowing everywhere, which is often one of the things that tracheostomised patients hate the most, is a trachea shield. And that can often be a little bit of a come-on to really getting on with this mask. Is we can now remove this tracheostomy shield because you're using your upper airway for humidification now. So, how do you actually do it? Once you get this slide under control, it's done. It's only a few little pointers, but it does take a little bit of time. Some patients take to it much better than others, obviously, but we start with initial trials just holding the mask in place, not trying to strap it on and make it all very confronting, because it is a confronting situation for these patients. They've already had a hard time, often a long journey through ICU, and a hard time getting off ventilation to start with or starting to breathe spontaneously. So really making it as low stress as possible. So just holding it on their face in the beginning, getting them used to having air now blowing at their face and down through their nose and mouth, which they haven't been used to for quite some time. So pretty low pressures, and starting with just a spontaneous time mode. Low pressures, low IPAPs and EPAPs to start with. I don't worry too much about trying to control upper airways or match intrinsic PEEP in the very first trials, just with a low backup rate and wide timing windows. You might use a ramp on the machine, so where it slowly just builds up from its starting pressures until the set pressures that you've actually set. And then, of course, there's titration that needs to go on. Once a patient can tolerate the mask and a bit of air blowing, and you know that you've got over the first 5 minutes, you're probably on the road to success. Then you've got plenty of time to actually adjust your settings until you feel that they're getting satisfactory tidal volumes and you're matching their respiratory rate, and you're actually doing what you need to do with the ventilator, which is giving them a rest. We always start with these daytime trials, often in the afternoon when patients are a little bit more tired, and I'll encourage them to have a little bit of a rest in bed with it so they can be as relaxed as possible. Once they're able to tolerate an hour or two, they really are ready to have a go at it overnight. And I don't wait too long between those two things happening. Once they've proved that they can wear it for an hour or two and they're not too confronted by the mask, they can deal with the air blowing, we have a bit of a go at an overnight trial, with the backup plan that if, they don't like it or if things go a bit pear-shaped in the middle of the night, we just take the mask off and go back to the invasive ventilator. Both equipment is left by the bedside for quite a few days. Obviously, there's continuous oximetry overnight, and so if the nurses are unhappy with what they're seeing in the patient, even if the patient's not complaining, there's a low threshold for putting them back onto an invasive ventilator as well. Once they've managed to establish a whole night on non-invasive ventilation, get a gas in the morning, see how well we're doing. And obviously titration continues from there. So once we've got them going at night and had a couple of successful nights, everybody gets a big pat on the back. Patients are usually pretty happy at this stage. They've realised that there is another way for them to feel safe and to support their breathing at night, which doesn't involve having a machine attached to the tracheostomy necessarily. So we can really start thinking about decannulation. Clearly the other boxes have been ticked about secretion management. The physios have got a good plan for how we're going to deal with that if they get a secretion problem in the future. And we can start to think about pulling the tracheostomy out. We often do consider using a mini tracheostomy for a short while, particularly if there's a significant impairment of cough, and that's quite common in our neuromuscular patients. And it's there as a nice safety backup feature so that we can access secretions if we need to. Once the tracheostomy is out, obviously there's a stoma that needs to be covered, and occasionally stoma leak can be a problem when you're applying positive pressure over the nose and mouth, particularly if the pressures are reasonably high that you need to apply. Again, our nurses are very good at actually dealing with stoma leak and reinforcing dressings and doing all sorts of fancy things to stop that. It's rarely a problem into the long term. I can only think of, a couple of occasions where we've had persistent leaks, which have been not actually affected ventilation very much, but are very annoying to patients into the long term. So just looking after the stoma carefully and doing all the right things with reinforcing dressings usually gets you over that problem. Having a mini track in place, of course, means you've still got a bit of a leak. So I avoid mini tracks unless we really think there's a strong need to have them there. So how do we know if we're going to win or we're going to fail here? Again, I think the most important thing is having everybody on board, the patient and their family, that they're all happy with this as a forward progression and it's something that's really good for the patient and is going to be really important in terms of getting them out of hospital. And if you don't have the patient on board or very reluctantly being dragged along with you, it's a really hard road to get them established on NIV and for everyone to feel comfortable about pulling the tracheostomy out. Obviously, early tolerance of the mask is a good predictor that you're going to be successful, and there's very few people I've ever found that are truly claustrophobic of a mask. Most will tell you they are when you first show them one. They almost never are once you actually get it going. Of course, we can consider all sorts of different masks and playing around with that, but most people, once you explain to them how the mask works, how it's got safety valves in it that they can't suffocate inside the mask, etc., are usually pretty good with it. The other thing that's important is to obviously have nice synchrony between the patient and the NIV, and that's where having the right machines really helps. The patient should be doing whatever they want to do and the machine should simply be following them. Patient, I always explain it that the patient needs to be, you're the master and the machine's the slave, and it should just follow you along. And if you can get that nice synchrony happening between the patient and the machine, they'll be much more tolerant of it. Obviously, having some successful daytime trials, it's good to have success during the daytime when there's people around and they're more awake and it's not so confronting. And having good, confident staff support, particularly overnight, to be able to gently encourage patients to continue with the mask and to troubleshoot any problems that they might have overnight is a really, really important factor. So what it looks like, as be one of our patients who we've now got established successfully on a mask ventilation, and you can see the valves in place. We haven't decannulated him yet, clearly, but that would be the next step. There's a buzzer there that's this patient is very disabled, so there was the jelly bean buzzer there so he could easily call for help if he needed to. One of the patient's fears, obviously, is that they can no longer call out easily if they've got a mask on their face. But you can reassure them with a valve on, they can still talk and people will still hear them, and we set them up with some secondary communication system anyway, just for their own reassurance, obviously. And really, that's as easy as that. You just need to put the mask on and away you go.
We've got a minute or two if anyone had any questions for Linda.
Or James.
Or me, yep.
Yeah.
Yep.
Yes, indeed. Ah. Yeah. 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 That's a good question, and it's again another whole area that I didn't have time to talk about. Quite a bit of thought goes into the right sort of tracheostomy for our patients, and frequently when we're starting cuff down trials and valve trials, we often switch patients to these Bavona tight to the shaft tubes, so that there's much more room around the tube. You can facilitate speech and airflow around the tube much more easily. So it's a common tube for us to use. Obviously, this is a decision that's made often early on in the piece before we've even started or thought about NIV trials when we're thinking about placing a valve to start with. So it's a decision that's often made along with our speech pathology colleagues and the medical team to decide on what sort of tube to use. But it would be our most common tube of choice, the Bavona. Yep, for all those reasons.
Thank you. Thanks, Linda.
Okay, great. I can go?
Yes, you can. Well done. So I've got the honour of introducing the next speaker, who's on his way up. Brendan is one of our guests from the United Kingdom, and the slides have just gone on this screen. Sorry, Brendan, but they're up there.
You're talking.
Yeah, exactly. Oh, is that what's happening? Yeah, sure. So Brendan is one of the consultant anaesthetists and intensivists at the it's at the Manchester.
Yeah.
Manchester Hospital, the University Hospital there. and has been one of the national leaders within the UK and also international leaders in tracheostomy safety for quite some time, and is one of the main drivers behind the GTC. So Brendan's going to talk to us now about notes from a small island with a big population, from incidents to the UK National Tracheostomy Safety Project. So over to you, Brendan.
Thank you very much. So thank you for the introduction. One of the nice things about spending such a long time in an aeroplane is that you have a lot of time to change your slides, which is exactly what I've done, which is why it's on a Mac. And hopefully, up there. Well, hey, great. Okay, so my name's Brendan McGrath. I work in Manchester. My hospital's called officially the University Hospital of South Manchester, or Wythenshawe, as it's known to the locals. And I've been asked to come and talk to you about our story, about what we've done in the UK, from a sort of personal perspective, again, like you've heard from many of our speakers, but to sort of tell you how I got involved in trachea care and some of the trachea problems which I've come across, and how that's evolved into a regional, then a national problem, and obviously linking in with the GTC. I'm sure you'll see there's a lot of familiar issues, a lot of repetition in what you've heard already, and hopefully this will sort of inspire you to either continue doing what you're doing or to get involved in what we want to do with the GTC. So Manchester is pretty much in the middle of the UK, in the north of England, as you see there, famous for Man United, unfortunately, Manchester City, which I think has got a few links with Melbourne, and the birthplace of the Industrial Revolution, they tell me, but also of the NTSP. So I was just going to follow on with what we've done this morning and sort of, as I say, to try and sort of tie in what we've done in the UK. And you'll see how that fits in with the sort of GTC's mission and the GTC's sort of key drivers. There's been a few mentions this morning of this report called the NCPOD report, which I think it's worth just dwelling on just a little bit, and I'll just expand on some of the key lessons that have come from that report, which I think are very relevant to this audience. And I think the sort of key thread, again, of what I'm trying to do is explain what we've had to go through in the UK to get to where we've got to, and to try and save some of you lot having to go through the same sort of difficult, unpleasant experiences that undoubtedly some of us are going to have to go through. So essentially, it's notes from my very small island. I need to thank Tanis and the TRAMS team and all of the organisers here. Having organised the European launch, I can fully empathise with what a huge amount of work it is in organising the Australasian launch. I actually used to work in Melbourne. I lived here in 1999. I worked up at St Vincent's for about 6 months, and just to prove it, there's my badge. You'll see I had a fine head of hair back then. I was slightly dined out a bit more on Australian pies. Then I worked in the Anglis, which is somewhere in either east or western suburbs, I can't quite remember. And then down in Geelong, sporting a fine pair of sideburns, and you can tell I didn't get out much. I didn't have much of a tan, seeing as I was living in Australia. And then out in the Dandenongs, that was Hamilton-based hospital. So I had a good tour of Australia while I was here, and then I went across New Zealand. Embraced everything to do with Australia that I could. Soaked up all of your fine culture. And I know there's been a bit of mickey taken about the dress sense this morning, and I'm not as smartly dressed as Stephen Worrell, I'm afraid, but I am still wearing my R.M. William boots that I bought in 1999. Although they do now leak, I'm afraid. I'm going to refer back to this timeline a number of times as I talk over the next sort of 20 minutes or so. And I'll keep coming back to that, because obviously quite a lot's happened over the last sort of 6 to 8 years to do with tracheostomies. Okay, so we've dwelt on this already. So what sort of problems happen with trachea patients? I'm not going to labour it all again, but I'm sure a lot of you in this room, because of what you do and why you're here, will have had problems with trachees. We've all probably got horror stories, things that we've reported, things we've not reported. And certainly my interest in sort of trachea safety happened in about 2006 when I was a resident in a hospital in the north of England, and I got dragged on my first day in a new hospital into a side room to see somebody blue with a bit of plastic sticking out their neck and lots of people running around with their arms in the air. And I said, okay, what's going on? It was pretty obvious something bad was happening. The nurse is on a break. The notes are about that thick. didn't know why they had a trachea, how long it was in for, what their upper airway was like, all those sorts of things that you want to know right now. And when everything had died down, and we fortunately managed to solve that problem, we then started asking about where's the kit. You know, they had to get kit from a theatre that was up a flight of stairs, and then, you know, this whole idea about not having information immediately available. Those sorts of problems, when we start talking to our colleagues and talking to people like yourselves, you know, we've all got stories like that, and that's what made me start to think, well, we've got to find a way of doing this better. We don't have trachea problems that often, fortunately, but when we do have them, because it's patients' airways, then things can go wrong quite spectacularly, and they can get worse quite quickly, as I'm sure you're all aware. We have a system of capturing these incidents in the UK, probably not dissimilar to some other systems in other parts of the world, but our system is one that we can interrogate. And if you have an incident, for example, on our ICU, it gets reported to the sort of central hospital, local sort of governance department. It's then reflected back to us to actually look at, you know, could we have done anything different? Were there any omissions in care? Do we need to change things, stop happening again? It also then goes off to this data warehouse, which Tony talked to you about this morning. And if you ask the data house nicely, they will, you can ask them some questions and they'll give you some data back. And that's what informed us for those critical incident reviews that Tony was talking about. And it's not until you get a lot of people in a room like yourselves and we look at a global collaboration that you actually find out that all these problems are going on in Auckland and in Melbourne and, you know, all of the places all around the world. It's the same sort of things. This data told us that essentially there's 4 groups of patients with trachees. We have surgeons doing surgical trachees as either single procedures or associated with other head and neck procedures. We've got percutaneous trachees in the ICU, and they've not been around that long, really, when you think about tracheostomies. And certainly in the UK, what that's done is it's changed the population of patients knocking around our hospitals who've got tracheostomies. They've gone from being fairly elective surgical patients, by and large, through to these sick ICU patients who will have tracheostomies and end up on our wards and outside some of these sort of traditional comfort zones, if you like, for tracheostomies. The split's a bit different in the UK as well, in that I think we saw some slides this morning saying it's about a 50-50 split between surgical and pert trachees, perhaps in Australia certainly. It's about 70% percutaneous trachees now done by intensivists, generally in intensive care now, in England and Wales certainly. There's the paediatric trachea population, and that's Chevalier Jackson showing off. He can do them in the back of his car back in the day. But certainly patients who are kids that need tracheostomies are growing up to be adults that still have tracheostomies, which then come with a whole load of translational problems into the adult services. And then we've already seen this story this morning, and you know, patients like Colin out in the community who you know, may need to come to hospital for something completely unrelated. He will pitch up at our emergency departments, he'll turn up to outpatient appointments, and our hospitals have to be geared up to look after patients who are perfectly well in the community, who are going to turn up and come to our hospitals. I'm not going to dwell on what sort of harm, because you've heard this a lot this morning. You've even seen the same slide. But there's lots of evidence out there, that some of which you'll be aware of from your own institutions, your own areas, some of which days like this are sort of bringing it to your attention, that it's the problems in America, Europe, Australasia. They're all the same sort of things. And the sort of themes, I'm sure, will be very familiar to you, depressingly familiar. We unfortunately had a tracheostomy incident beginning of July in my hospital, about 25 yards from my office, which highlighted exactly all the things that I've been trying to put right for the last however many years. And, you know, it's a difficult journey, and it takes time to get these things right, but the themes are all recurrent. And when you delve into them, this is the sort of thing that we got to move away from. So this is how we were detecting tracheostomy incidents in a data set that we examined in a lot of detail, and around, the data was from 2006, so getting on for 10 years ago. But detecting tracheostomy and airway problems by desaturation, bradycardias, hypoxic cardiac arrests, it's too late. And this is an ICU data set. You can see this complete lack of capnography in these tracheostomy incidents, which, you know, some of the work that not just me, but plenty of other people have been doing, is sort of try to solve some of these underlying problems. But what is clear from this sort of retrospective incident analysis is that we're seeing the tip of the iceberg. You know, I'm sure we've all done things at work that we're not very proud of. We don't always want to jump up and down and wave a flag and tell everybody about it. And there's estimates that will tell us only probably about 1 in 10 of these incidents are reported. So we've got to look elsewhere. We were fortunate enough to have a big national project, which again came out of anaesthesia intensive care in the UK, called NAP4, which highlighted, again, very similar problems to ones that we'd already come across. And a result of some of these bits of work that were going on, these sort of national recommendations were made. So, standardising equipment, making sure if you need to sort out a trachea problem, you've got the tools to be able to do it. And again, I've personally been to incidents outside of critical care units, outside of these sort of specialist areas on wards, and you say, where's the spare tube, where's the suction? And you're greeted with sort of blank faces. So, you know, increasing this sort of awareness of what you need in an emergency is essential. Staff knowing what to do in an emergency, you know, it makes common sense. Use the right sort of tube. So we've heard a couple of talks about the different tubes available for different purposes. If the staff looking after those patients at 2 a.m. on a Sunday morning have never seen that tube before, it puts you in a difficult position. Education, putting the patients into safe locations, and then if you don't need a tracheostomy anymore, taking it out. But in order to do that, you need systems in your hospital set up to detect that when that time comes and to be able to do it. So if we fast forward a bit to the right-hand side, to this NCPOD report, and Tony pulled some of the highlights out of it this morning, so I won't go over it in huge detail, but there is some important stuff in there that I think you should know about. I don't think there's any need to do this again in other parts of the world, because I think we've got all the data that we need. And I bet if you did it again down here, for example, you'd find exactly the same things. I didn't come up with the title. I don't know if it's corny or not, but you get the idea. It was a review of patients who had trachees in England and Wales. Ran over 11 weeks, 2,500 cases. So they tried to capture every single tracheostomy insertion that was performed in this 11-week period at the start of this year. As Tony said to you this morning, there's a lot of detailed reviews as well. So about 400 sets of case notes were taken and scrutinised by a volunteer panel of experts that were vetted. About 70% of the trachees were percutaneous, mostly done in small sites, not big teaching hospitals. And the average age of patients having trachees was 61 years old. Sorry. These figures are slightly different to what Dr. Duke presented this morning about the Australian perspective, but we'd had a guess at how many trachees we do in the UK because we didn't know previously, and rather embarrassingly, so we bunged them in willy-nilly on the ICU when we weren't counting how many we were doing. But these are figures of your typical UK ICU, where your typical ICU this is an average across the whole country. We're getting about 600 sick level 3 sort of ITU type ventilated patients per year, and most ICUs will see about 1 trachea per week, so about 60 trachees per year. Our trachea rates per admission for a sick patient, so about 9%, which is similar in the US and Europe, and depending on which way you look at the data, very similar to down here as well. And your typical patient on an ICU in the UK will spend about 12 days on the ICU with the trachea in, and about 9 or 10 of those days will be ventilator dependent for your average patient. And we had a guess at some figures that were not too far off. Now these are figures about tracheostomy insertion. So these were the body mass index of the patients in the NCPOD study. And you can see that over 60% of patients were classed as overweight or above. So I think that's a common problem in all the Western world, that our patients are getting bigger. Now, our tracheostomy tubes are not necessarily getting bigger. They are creeping bigger. So some of ours that we can get in the Northern Hemisphere are, points of millimetres slightly longer. But I think one of the things that this report recognised was that we probably need to be putting bigger tubes in more of our patients. A lot of patients who require a tracheostomy have a difficult airway, and this is particularly relevant to anyone involved in actually putting trachees in. that about a third of patients who required a tracheostomy had a documented difficult airway where they had trouble. That's important to communicate afterwards. You know, if it took 3 anaesthetists 2 hours to get a tube down the patient's mouth, you need to know that at 2 a.m. on a Sunday if the patient turns blue. And you need to know that pretty much straight away. So that's important at the time, but it's also important afterwards as well. And the sort of key findings there, I mean, this didn't reflect too well on us in the ICU, weren't consenting our patients so well. Checklists, not very good. But again, these sort of protocol-driven things that the GTC is really pushing can really help in that situation. And stupid things like, you know, the patient's on an anticoagulant and we're just about to perform a tracheostomy before somebody realises. This thing here that, you know, we're only putting in these longer tracheostomy tubes in about 10% of patients, when we're probably looking about at least 30%. And then they're picking up that, again, this sort of equipment availability is still not universally available. Okay, so the report then went on to look at tube care. I'll just skip to the key findings. So you can see that a lot of emergency tube changes happened early, so in the first week. And half of those tube changes were unplanned. And I'm sure you don't need me to explain that that is going to put the patients at more risk. Certainly if you've put in your tracheostomy tubes percutaneously, then the hole is pretty likely to disappear in that first week and can cause you all sorts of trouble. There was a lot of comment about discharging patients with cuff tracheostomy tubes to locations outside of critical care units that weren't necessarily geared up to look after them. So the obvious recommendations that come from that are that if you are planning to change tubes, if you're discharging patients with particularly cuff tubes in, you've got to send them to a place that can safely and competently look after them. Something that we've been using up in the UK, and certainly seen these in lots of other places around the world, including down this far, is these bedhead signs. And we use these to describe behind the patient's bed what their airway's like, what's the hole in the neck for, who did it, when they did it, and were there any problems. And then importantly, who to call in an emergency. And again, all the hospitals set up differently, but we have these stupid situations where you have a patient who's blue and you'll have ENT arguing with Max Fax about whose patient it is, and ICU saying, well, nothing to do with me, which clearly we need to put some thought into before the emergency happens. I'm well aware there's some surgeons in the audience, and surgeons like to put bits of string in patients' necks. Sometimes they don't always tell us what they're for, which again, when they're there, say, oh yes, well I always do this. Well, that's great when you're there, but when you're not, we need to know. So again, if there's bits of string in the neck, we need to communicate them. And if you've got a tracheostomy or a laryngectomy, it's very difficult to know what's what. So if you spin the wheel, mix them all up, I don't know what's what, and I took half the pictures. So if you've got a laryngectomy, you need to know. And clearly the patients can't always tell you if they've had a laryngectomy. So we find these bedhead signs very useful in just trying to communicate what the patient's airway is and are there any special considerations about it. The report looked at how the composition of the teams that make up that look after patients with trachees. And this is Mo Farah and Usain Bolt, who are obviously copying and learning things from each other down in the Olympics. But that's certainly something that I learned through sort of collaboration and working with colleagues. A lot of things I'd never thought about, from physios, from speech and language therapists, from my head and neck surgical colleagues. And likewise, I can remember talking to some of the surgeons about sort of principles of oxygenation, which perhaps, you know, they were too busy trying to stick things down deep, dark holes. So there's a lot of learning we can do from each other. The next couple of slides talk about where we look after patients. And you can see there's a huge range of wards that we're looking after patients in this particular study. And that's illustrated as an example from my hospital. This is a chap with a laryngectomy who came into hospital with a bit of chest pain, and you can see he had a pretty thorough tour of the hospital wards. But a lot of these areas were not, they didn't know what a laryngectomy was, they didn't know how to look after him. And you can see, unfortunately, this poor chap ended up having a respiratory arrest due to a blocked stoma, and that happened on a coronary care unit. because they weren't geared up to look after him. Again, as we've heard, no fault of the staff, they'd never seen one before, but our system wasn't geared up to safely look after this particular chap. There's lots of different clinical teams involved, and the makeup of the teams will vary depending on exactly where you work. But the recommendations again came from this, saying, look, it's pretty clear when there's expertise that exists in this room, in your hospital, make sure you use it. And certainly it was pretty obvious that in those teams that were using the expertise and the proper multidisciplinary approach, or truly multidisciplinary approach, that things were certainly better. I'm very aware that there's a number of patients and relatives in the audience, and I'm sorry if these next couple of slides appear a little blunt. But patients who require tracheostomies, as we're aware, and we've discussed already, unfortunately often the need for tracheostomies is highlighting the fact that patients sometimes aren't very well. And so this death rate here is not due to airway complications, it's due to the fact that patients often requiring tracheostomies are sometimes very dependent patients, sometimes have a lot of medical problems wrong with them. You can see that about 30% of patients were leaving our ICUs with tracheostomies in, and certainly as intensive care representation in the UK, you know, we're responsible for this 30% of patients leaving our unit and being managed outside of our unit. We need to be careful that those locations after discharge are safe to do so. We'd seen some data from the US a few years ago where if you look at, again, mortality of patients with tracheostomies, we're looking at 20% mortality. If you add in age and add in some comorbidities, we can approach 40%. Mortality. So, you know, 10% of children, 20 to 40% of adults are not going to survive with a tracheostomy. And I think the message is there clear to all the teams involved in choosing or deciding with patients or with their relatives, if possible, think carefully about who gets a tracheostomy in the first place, because it may not be the thing that's going to decide whether the patient survives or not. I think that's an important message to get across. We're booting people out at strange times of the day as well, which clearly, you know, you don't need a report to tell you that that's intuitively bad. But, you know, we were looking after patients in specialist locations, in specialist wards, specialist ICUs for 50 days, and then discharging them at midnight on a Saturday because of bed pressures. And clearly, that's the wrong thing to do. But again, unfortunately, it's happening, and hopefully these sorts of reports are going to be enough to try and stop that sort of thing happening. The assessors looked at what they described as the overall quality of care, and you can see that there's good practice considering about 40% of critical care management tracheostomies, very similar figures for the ward, which leaves room for improvement and all the other stuff to the right-hand side at about 60%. So, you know, there's a lot of room for improvement, and we're not talking about getting a load of specialists to attend the patients and perform complex airway management. We're talking about the basic things done well. Whose problem is it? Well, we try and apply this sort of 2 a.m. test. So on a Sunday at 2 a.m, who's looking after your patient when you're not there? How do you know they're competent to do so? And I think the best way to sort of illustrate that is to play you a little video from a relative. Oh yeah, it's on. Hopefully you'll be able to hear this. Yeah.
By the time he'd arrived there, she'd already died. They said that the tube had become blocked and that she couldn't breathe and her oxygen levels had become really low, so her heart had stopped. They did try to resuscitate her, but she was too weak.
Okay.
And that's when we found out all the things that hadn't happened that should have happened for my mum.
Okay, but what sort of things should have happened?
All sorts of things. I mean, she should have had the trachea tube changed every few weeks, which, as far as I know, didn't happen at all. tube inside that that should have been cleaned every few hours. That's supposed to help stop it from getting blocked. And she should have had special oxygen that would have helped her breathing. And I don't think she ever had that except when she was on intensive care. Yeah, I mean, they did say that on that ward they hadn't had a patient who'd had a trachea for about 2 years. So I mean, it's no wonder they didn't know what they were doing. But you just assume, because it's a hospital, that they know what they're doing.
And I think that's a challenge for all of us, you know, just because it's a hospital, you'd think they know what we're doing. And when you've got new staff, high turnover of staff, new equipment, it's very difficult to make sure that you're ready all of the time. So, how do you improve care? So you've heard a lot about it already. If we extend the timeline backwards, and apologies to those who are in Boston, but I like this story. So this is a painting depicting the death of George Washington after he fell ill in 1799. So he was attended by a Scottish chap called James Craik, who was a surgeon from the British Army, who thought, this isn't very good. He had croup and obviously developing airway obstruction. So he sent for an American chap called James Craik. No, somebody else. I've forgotten his name. That chap. Elisha Dick, that's him. Who turned up and they scratched their head and they thought, right, what we need to do is do what we do best, which is to apply some vapours of vinegar and give them a laxative. That's good for airway obstruction. And they're very pleased themselves because the great man had a giant discharge from the bowels, but didn't do much for his airway, as you would imagine. And then a third European turned up and he said, I've seen this thing called a tracheostomy. Maybe we should do it on him. And they all thought, we're not going to stick a knife in a president's neck. And so they discussed it and decided not to, and he died of airway obstruction a couple of hours later. Now, they then reflected on this, and they published this in the Philadelphia Medical Journal, where you can see that they thought about it. They were aware of other practices going on elsewhere around the world. They decided not to do it on this occasion, but they wanted to promote and get the word out that perhaps next time we had a problem, we might be able to do something about it. So a very early example of an international quality improvement collaborative, I'm sure you'll agree. So all these things you've heard about, there's lots of good examples how to improve care that we've discussed just now and that you've heard about today already. How do you measure it? Well, just measuring helps, as we were discussing this morning. Data, really important. And then all of these institutions and individuals have shown us some of these surrogate markers of quality that we can demonstrate that we're actually doing something. Just simply by applying an educational programme, which is essentially what the NTSP is, we can show a reduction in the nature, severity and frequency of incidents, which we've been able to show in the UK. So essentially what we did was get everyone around the table and we got all the different working parties together from different specialities, every sort of key player, plus patients, plus relatives, plus carers, and sat them all around in a room and tried to work out what to do. Our initial focus was on emergency algorithms, and that was our very first sketch that I found when we were going back talking about how we use the simulators to develop these algorithms. And this turned into various guises, and we ended up coming up with these emergency algorithms, which were published in 2012, one for a patent upper airway, one for a laryngectomy. We got endorsement from all of these different groups, which is really key, certainly in the UK and Europe, in trying to push this sort of standardised approach to managing emergencies forward. And we've been teaching these now for 6 or 7 years, now supported by ALSG. And we've done them now in Scotland, Wales and Ireland, which means it's international. And ALSG they represent, I think, 37 different countries. So, you know, there are these courses going on, which hopefully will provide this sort of standardised approach. We've bunged a lot of stuff on the website, which is now obviously being superseded pretty much by the GTC stuff, and e-learning, which we did, which TRAMS have done as well. So again, we try to just get that sort of education out there through various means possible. You've got to have an app nowadays, and one of my American colleagues asked me this morning, so how's the app going? How much money have you made out of it? And of course the answer is none, because it's free, but it's been downloaded 11,000 times, so I'm kicking myself we didn't charge £1 for it. I would have come first class. This is Bob Sutcliffe. He is our tracheostomy patient champion. I suspect he's in bed and not watching this just now, but he holds the world record on our ICU for length of stay. And getting patients involved is one of the key principles behind what we've been trying to do, certainly with the NTSP and then definitely with the GTC. And we could sit around for 6 months deciding what endoscope we're going to use on our for our tracheostomies. But clearly the patients don't care. They want to know, when's this coming out? Will I have a scar? All the things that the patients want to know. We're very fortunate to have a patient come and talk to us in London who again had some really fascinating insights into life with a tracheostomy.
For inviting me to talk today at your UK launch. I thought I would tell you a bit about how my tracheostomy came about.
From Professor Hawking is on the website, but essentially it talks about his experience as a patient and what's important to him. And he talked about how he couldn't swallow and his difficulty breathing. All the things that the patients want to know about, and the sort of how frightening it is when you're developing these problems. So we started with emergencies, but clearly prevention is much more important. And this sort of notion of basic care done well is the key behind stopping all these things happening. There's all sorts of guidance available. We've bunged all ours together into a manual, which again you can find all sorts of resources on the website, which takes us right up to the GTC. So all of these things that we've put together through the GTC. And if you add together the resources that are out there already with these exemplar institutions which you've been hearing from, truly multidisciplinary care, comprehensive staff education and involvement of patients and their family, and then a tool to collect the data, I think we're there, aren't we? We're looking at a very detailed assessment of whether this stuff works in the UK at the moment, something called the SHINE project. Which is hopefully going to, we'll report that in about a year's time, which is a financial and quality report to the NHS, which obviously be available elsewhere as well. So again, looking for some hard data that this actually does work. The future is the GTC, from national in my perspective to global. New working party looking at all sorts of different things. We're looking at paediatric emergency guidance at the moment, education, all sorts of different things going on, partnering with people like yourselves, and then evaluating whether our stuff works. So in summary, it's a team game. Most incidents are preventable, and clearly collaboration locally, nationally and globally is the key to success. Thank you very much.
Yeah. In the interest of time and a nice afternoon tea break, we'll keep moving, but Brendan will be available at the end when we have our open discussion. So the next speaker, Annalisa. Yes, Annalisa's on her way up. Annalisa Soot is one of the senior speech pathologists at the intensive care in Prince Charles Hospital in Queensland. It's braving the cold down south. And she's going to talk about some of her fascinating research, which I've heard a little bit about, in speaking valves and their impact upon weaning and decannulation time. So over to you, Annalisa.
First of all, I'd like to thank the organising committee for having me here. It's a true privilege. So speaking valves, as you all probably know, are one-way valves that enable the functional use of the glottis. Some of the speaking valves are designed to be able to be used inline in the ventilator circuits. Some of them are not, but in most ICUs around the world, the ones that are designed to be used in line with the ventilator are not used in line with the ventilator's very often due to mainly concerns about ventilation probably not reaching the alveoli and potential risk of lung collapse and harming patients rather than benefiting them. So if we look at this little video here of alveoli, you'll see some of these alveoli popping up more and more. There's still some areas of atelectasis here, but you can see them all popping up. So ideally, we want them all open, obviously, for the gas exchange to occur. You can think of the alveoli as little balloons. Balloons are always hard to inflate at first, so it's best for them to be kept open rather than opening and closing and causing further damage. On another video here, you can see how there's a set of lungs here, and there's initially not a lot of end expiratory lung volume there, and lungs are quite collapsed at the end of expiration. Potentially, then obviously the alveoli being collapsed, you can see areas of atelectasis here, which by adding more positive end expiratory pressure is opening up nicely, and end expiratory lung volumes end up being a lot greater as well. You can see all of these areas of atelectasis here resolving eventually. So by having a speaking valve in the ventilation circuit, there's no expiration back to the ventilator. So the ventilator is not able to tell us, say if it's someone on volume-controlled ventilation, we don't really know how much air ends up in the patient's lungs due to the leak in the system during inspiration already. Knowing the theory that air always travels the path of least resistance, we're potentially overinflating some of the areas, not inflating some of the areas enough and causing that atelectasis that I already mentioned. So it's really like blind leading the blind, and even more so when we have a one-way valve in line with the ventilator. So I guess the concerns from the multidisciplinary team are quite justified. I'll give you a bit of an overview of the Prince Charles Hospital Intensive Care Unit where I work in, and what the history is with speaking valve use there and where we're now. So it's a primarily cardiorespiratory intensive care with about 70 tracheostomised patients a year in the unit. All of our tracheostomised patients are ventilated, and once they no longer need mechanical ventilation, they're often decannulated soon after. When I started in the unit in December 2011, inline speaking valves were not used, and there were general beliefs that cuff deflation that is needed for speaking valve use causes de-recruitment, therefore potentially being deleterious to patients weaning off mechanical ventilation. We had but exactly 9 patients back in 2011 that had a chance to use a speaking valve, and that was on average initiated 1.2 days before decannulation. So the patients were well and truly off mechanical ventilation by then and only needed a couple of litres of oxygen via their tracheostomy tube. And the speaking valves were not actually, the ones that we were using were not designed to be used in line with the ventilator anyway. So it was definitely a quiet zone and there were no inline speaking valves used. A year after though, 43 patients out of the 70-odd tracheostomised patients were using a speaking valve, and on average 10 days before being decannulated. Average decannulation time then was 14 days. So out of the 14 days, patients were actually verbally communicating for 10 days. And now, which is 2 years later, to quote one of our intensivists, if our tracheostomised patients are awake in intensive care, they talk. And if they're not talking, then something's wrong. But how did we get there in a situation where there were a lot of non-believers? Most of the team was thinking that, cuff deflation and speaking valves could potentially harm our patients rather than do any good. And we've heard a lot about incidents today already, and obviously by using a speaking valve that requires cuff deflation in mechanically ventilated, very sick patients were potentially adding to the lot of incidents as well, which there was a lot of concern about. I'd like to say that we had a perfect patient, we had perfect team, and we had perfect equipment, which is not available in not too many units around the world. The patient, not the one on the photo here, but the patient that we first started using the inline speaking valve with was a 21-year-old guy with Guillain-Barré. On the background, he also had cystic fibrosis, hence ending up in our ICU, I guess. His upper limb mobility and oromusculature movement were very, very, very poor, so making any sort of AAC options quite impossible. Eye gaze, I guess, could have been something that we should have maybe looked into a bit more, but luckily the team wasn't too much against innovation, and we had the amazing piece of equipment there that our critical care research group had years of experience with in using for other projects. So we thought we'd give it a go. So more about the equipment. You can see the EIT, as I'll be referring to it from now on. You can see the EIT belt around the patient's chest here, and it's connected to the EIT machine that's next to the patient here with the screen sort of giving us immediate feedback about air movement in and out of patients' lungs. And you can also see an inline speaking valve here that the patient is wearing as well. So how does the EIT work? So it's basically a real-time, non-invasive, radiation-free bedside imaging equipment or technique. It gives us dynamic visualisation of regional ventilation as well, for us to be able to see where the air is exactly going as well, not just how much. It works with 16 electrodes around the circumference of the patient's chest. So small electrical current is injected through the electrode 1, voltage is then read at electrode 2, and this is repeated across all of those 16 electrodes, creating 208 potentials per image. And the difference then comes due to impedance or resistance to the electrical current moving through their chest cavity. The images then, single tomograms are calculated by using those 208 potentials, and the tomogram then represents changes of bioelectric properties of the tissue due to either ventilation or perfusion or anperfusion. You can filter out perfusion just to look at ventilation, which is what I'm doing for my project, or you can look at perfusion as well. So this is a typical EIT image with anterior regions of the lungs at the top, posterior at the bottom, right is left, left is right, like often with X-rays. Most of you are probably more familiar looking at CT images, so there's one of a sheep here, and equivalent EIT image next to it here. So you can see where there's likely to be less resistance to the electrical current moving through the chest cavity is then translated into more air in the lungs on our EIT image, and the other way around where there's not a lot of air in the lungs. So what has the journey been like? We started off with a couple of case studies, and to everyone's surprise, we found that by putting the speaking valve in line with the ventilator or in line with, say, high-flow oxygen to patients that were doing trials off the ventilator, we found that end-expiratory lung volumes were actually significantly greater with the speaking valve in situ, which led us to turning it into a formal research project with ethics approval and luckily some grant support as well. But as with any research, obviously, there's always new questions that come up, and some of them can actually be really tough. So my journey continued with a PhD. Luckily, managed to get a PhD scholarship as well to give me some valuable time offline my full-time clinical duties. I've mentioned most of this general data already, but I'd also like to mention that we did a little data audit looking at 2011, which was pre-implementation of the inline speaking valves, and comparing it to 2012, which is the first year where inline speaking valves were used in the unit. We found that there was no change in time to decannulation or ventilation duration. Also worthwhile mentioning, the patients in 2002 were actually sicker. When looking at their Apache and SOFA scores, they were sicker. So we're quite happy that sicker patients using something new ended up having same sort of decannulation or ventilation duration. Obviously not measuring apples to apples here, but that was all we could compare at this stage. I'll give you a bit of a summary of the first 10 participants in my study. We're further along with the recruitment now, but I've also done some preliminary data analysis on the rest of the patients, and the data presented here is very similar to the ones that we've seen with more participants now too. So out of the first 10, we had 7 patients on high-flow oxygen, which is defined more than 30 litres a minute of oxygen via the tracheostomy tube. So these were the patients that were doing trials off the ventilator already, but still needing mechanical ventilation support at least overnight, if not more. And we had 3 that were on pressure support ventilation. So not surprisingly, both patients and the nursing staff looking after them were reporting significantly improved success with health communication when the speaking valve was in situ as opposed to when it wasn't. We found that end expiratory lung volumes were significantly greater when the speaking valve was used off the ventilator on high flow oxygen. We also found that end expiratory lung volumes were significantly greater during and post period of speaking valve use for patients on pressure support ventilation. So it really looked like the speaking valve was acting as a recruitment manoeuvre. So all of us here who are working in intensive care probably know the enormous amount of research that's done around recruitment manoeuvres, and with the latest meta-analysis coming out and saying that none of them really make a huge difference. I'm being really cheeky here, and I might add speaking valve to the list of recruitment manoeuvres. We also found that oxygenation remained stable at baseline during the use of speaking valve and post half an hour on the speaking valve. End-tidal CO2 was stable or slightly higher with the speaking valve in situ. And we're also measuring thoracic cage versus abdominal mobility with respiratory inductors plethysmography belts. That was a hard one to say. And we've found that abdominal activity was generally increased with the speaking valve in situ, which, knowing how quickly diaphragm weakness develops on ventilator patients, could be something significant as well. So to summarise the results that I've given you over the last 2 pages, there's a video here of some of the data that we're collecting for every patient, and this one is a female patient on pressure support ventilation. So the first column is before, at baseline ventilation before we put the speaking valve in line. The middle one is with the speaking valve, and the last one is after half an hour on speaking valve. Up the top you've got the electrical impedance tomography images. It's sort of hard to see just looking at the video as to what the end expiratory lung volumes are doing or what the tidal variation is doing and all that. So parallel to these pictures that we can see at bedside, straight away the machine is collecting enormous amount of data using all the 208 potentials per image. So the Excel files that I need to analyse after recruiting the patients are enormous. Gotta love numbers. But even based on these videos here, you can see how the end expiratory lung volumes are actually higher when the speaking valve is in situ. Looking at the next line here, respiratory inductance plethysmography, you can see how the respiratory rate has dropped off with the speaking valve in situ, and the amplitude of movement is slightly higher. Now that's a summary line here of, I'll play it again, of thoracic and abdominal belt, but when I took the data apart, that it was mostly the abdominal activity that increased here. Heart rate was slightly more variable when the speaking valve was situ, but this is a female patient and we all love to talk, so they might have just been really excited being able to talk. End-tidal CO2, as I mentioned, was slightly higher with the speaking valve, but still remaining within normal limits. Oxygenation remained stable. Where to from here? Obviously, I'll need to finish recruitment. I've got 2 more patients to go. But I've already got, the team has got a lot of hypotheses ready to go, most of which we actually have started looking at already. So we're planning to look at, or have started collecting some data already on change in the use of sedative and analgesic agents. So quite often when tracheostomised patients are sort of first weaned off sedation, they might wake up agitated and frustrated and all that, and sometimes become a bit combative maybe as well, and they need to be resedated. But some of our thoughts are that maybe by introducing verbal communication or enabling verbal communication early, we might get rid of that second phase of resedation, but no data yet, obviously. There's some research that's been done on normals by Dr. Masseray, looking at the function of glottis in in balance and strength. So theory being that by being able to close your glottis, you're increasing your intrathoracic pressures, therefore getting improved core stability and upper limb strength. So similar research could be done with an open tracheae versus an inline tracheae, looking at the impact of the ability to use glottis on these areas. Impact on ventilation duration is obviously another area that everyone's very much interested in. We didn't show any difference between the first 2 years of pre-speaking valve as opposed to the first year with speaking valve, but now that we've got an sort of established practice of speaking valve use, we're looking at the next 2 years as well to see if we can see a difference. Obviously, any sort of RCTs with speaking valve as opposed to no speaking valve are quite difficult ethically. There's lots of research on post-intensive care syndrome. Patients have often mentioned that communication is definitely one of the factors leading to more or increased PICs. So by enabling earlier verbal communication, hopefully we're having some positive impact on PICs. And if someone can use their glottis, they can do a Valsalva manoeuvre, so surely it would have an impact on bowel management. Just to wrap it up, there was an article published in the New England Journal of Medicine a couple of years back looking at functional disability 5 years after ARDS. Obviously not all of our patients up there are ARDS, but they're respiratory, so hopefully there's some comparability. They reported on 3 areas, and pulmonary function was near normal 5 years later, and I guess we've sort of in the process of showing that we're potentially not harming patients' pulmonary function by using the speaking valves early. If anything, we might be improving their pulmonary function early on. Weakness is reportedly still a major problem. We might be helping by using the speaking valve if the theory on the impact of glottis on sort of strength and balance will prove to be correct. It's just estimating. And neuropsychological issues, as mentioned, communication is often a big part of it. So if we're improving the patient's ability to communicate, then hopefully we're helping. But back to the original question, do speaking valves have an impact on weaning the cannulation times? Well, we don't know. Hopefully, if they're improving respiratory function or if they're improving lung recruitment, then if anything, they might have a positive impact. But if we're looking at the functional disability 5 years after, are we really looking at short-term outcomes or long-term outcomes? Are we really asking the right question in the first place? I'd like to thank my awesome team, and I'd like to thank Sheng Feng from Fisher & Paykel for putting together this amazing video for me where all my data aligns. And just to keep in theme with the symposium here too, I think collaboration within our multidisciplinary team definitely led to innovation and allows us to excel, hopefully, continuously. Thank you.
So we do have time for a question or two, if anyone's got any questions for Annalisa. Prue.
So for my study, we're looking at 15 minutes at baseline ventilation, half an hour with the speaking valve and 15 minutes post. And the protocol is only an hour because the ERT belt needs to remain in situ. So we can't remove it and then put it back on and compare the data between the 2 sessions. So that's basically why. So we haven't had a chance to look at it with the electrical impedance tomography, but we do obviously clinically use it for a lot longer. And I guess one of the first indicators is just increased work of breathing.
And one last question from David.
So, you can apply PEEP with a ventilator, but my thought would be as a, person who takes care of the most interesting organ in the body, the larynx, is that maybe there's something dynamic about PEEP being applied by the larynx, if there's, ups and downs to it or whatever. What is your thought about that? Essentially, you're transferring the responsibility of PEEP from the ventilator to the larynx, right?
Yep. So I guess due to time restrictions, I also didn't mention that in the protocol where say someone's on PEEP of 10 on the ventilator, we put the speaking valve in line. We then drop the PEEP by 5 at this stage. I know there's all sorts of issues along, whether the ventilator even delivers any PEEP if the cuff is down and the one-way valve is in line with no expiration back into the ventilator. And there's some thoughts from the engineers that it's a ventilator-specific or ventilator-dependent then as well. But I guess the improved recruitment of the lungs is purely because of the physiological PEEP, plus a few, extra probably due to the necessity of having to breathe around the tracheostomy tube, not just via the upper airway.
Supplied by the larynx is much more dynamic than supplied by a ventilator. There's probably some benefit to that.
Yes. So basically just normalising the system as early as possible. Yeah.
Thank you very much, Annalisa. So it's afternoon tea time. We've got about 20 minutes, so come back in here at about 3:05.